Welcome to the Biopharma Business Intelligence Unit, where symbolic integrity meets strategic clarity. At BBIU, we go beyond the headlines to decode the structural forces behind global biopharma, AI, and economic realignment. If you value precision, verification, and symbolic depth, this channel is for you. Subscribe now to access our weekly briefings, dossiers, and intelligence reports, and consider joining our institutional tier to unlock early warning systems, custom metrics, and exclusive strategic insight. You're not just listening, you're entering the future of epistemic intelligence. www.biopharmabusinessintelligenceunit.com.
Section 1. Ocular Anatomy and the Ideal Path of Light to the Macula. The human eye is a highly specialized optical system designed to focus incoming light precisely on the macula. In the ideal case, cornea, primary refractive surface. The transparent cornea contributes approximately 70% of total refractive power. Its curvature ensures that light rays begin converging toward a focal point. Any irregularity, such as astigmatism or keratoconus, disrupts this process. Aqueous humor, transitional medium. This clear fluid fills the anterior chamber. Though it adds little refractive power, its transparency and stability are essential for undistorted transmission of light toward the pupil. Iris and pupil. Aperture regulator. The iris adjusts pupil diameter. In bright light, constriction meiosis increases depth of field. In dim light, dilation, mydriasis, maximizes photon entry but reduces sharpness. The pupil thus functions as a natural aperture. Crystalline lens. Dynamic refractor. Behind the pupil lies the crystalline lens, responsible for about 30% of refractive power. Its unique property is adjustability. Through contraction or relaxation of the ciliary muscle, its curvature changes to accommodate near or far vision. With age, the lens loses elasticity. This is the basis of presbyopia. Vitreous humor, optical conduit, a transparent gel filling the posterior chamber, transmitting light unaltered toward the retina. Retina and macula, focal plane. The retina converts light to neural signals. The macula, and specifically the fovea centralis, houses the highest concentration of cone photoreceptors. In the ideal optical state, light converges exactly here, yielding sharp central vision. Proposed pharmacological training for presbyopia, Benozzi protocol. 1. Mechanism of action. Pilocarpine, a muscarinic agonist, induces ciliary muscle contraction. This enhances lens curvature and improves near focus. It acts as pharmacological physiotherapy, training the accommodative apparatus through repeated stimulation. Diclofenac, a topical NSAID with high corneal penetration, reduces inflammation and discomfort from pilocarpine-induced strain or pre-existing ocular microinflammation. It also increases long-term tolerability of chronic therapy. 2. Clinical evidence. Argentinian study, ENC 766, mean age 55. Treatment involved eye drops administered twice daily with an optional third dose. Follow-up lasted up to 2 years, with a median of 434 days. Outcomes showed significant improvement in near vision across all groups, with no serious adverse events, such as increased intraocular pressure or retinal detachment. The most frequent mild events were transient dim vision, 32%, mild irritation, 3.7%, and headache, 3.8%. 3. Concentration-specific results. Pilocarpine 1%, 99% of patients achieved functional near vision, gaining at least 2 extra lines on the Jaeger chart. This concentration provided the best balance of efficacy and tolerability, with minimal impact on night vision. Pilocarpine 2%, 69% gained at least 3 lines, but with a higher rate of side effects. Pilocarpine 3%, 84% gained at least 3 lines, but adverse effects such as headaches, transient blur, and reduced photopic vision were more frequent. 4. Key insight. Less is more. 1% concentration offers optimal effect, maximizing ciliary training without overloading the system. Higher doses lead to more side effects without proportional benefits. 5. Strategic implications. A low-dose NSAID-stabilized pilocarpine therapy represents a disruptive alternative to glasses and surgery for presbyopia. It offers a scalable, chronic-use therapy with better patient adherence and the potential to shift the ophthalmic market from mechanical correction to functional restoration. Annex, Clinical Protocol, Phase 3, narrative version for general audience. This Phase 3 clinical trial is designed to evaluate a novel fixed-dose ophthalmic solution that combines pilocarpine 1% and diclofenac 0.1% for the treatment of presbyopia. The study is multinational, randomized, double-masked, and parallel group with at least 50 centers participating worldwide. Each participant will remain in the study for up to 12 months. The primary endpoint is assessed at day 30, while additional follow-up at month 3, month 6, 12 is included to document persistence of benefit and long-term safety. Objectives. The main goals of the study are twofold. First, to demonstrate that the combination of pilocarpine and diclofenac, the combo, is superior to placebo vehicle, improving distance-corrected near visual acuity, DCNVA, by at least 3 lines on standardized near vision charts measured binocularly under mesopic conditions 3 hours after dosing on day 30. Second, to demonstrate that this superiority is durable and persists at 6 hours post-dose on the same day. Key secondary objectives include the proportion of patients achieving at least 2 lines of improvement at 1 hour, day 30, the area under the curve, 0-8 hours, of near vision change on day 1 and day 30, the proportion of patients reaching Jaeger-3, J3, or better at 3 and 6 hours, confirmation of no meaningful loss in best corrected distance visual acuity BCDVA, standardized pupillometry under different light conditions, validated patient-reported outcomes, NEI VFQ-25 and night driving questionnaires, and the level of illuminance required for comfortable reading. The study also aims to establish the relative contribution of each component. Pilocarpine provides efficacy, diclofenac contributes tolerability, and diclofenac alone is expected to resemble placebo in terms of efficacy while confirming safety. Study design participants are randomly assigned in equal proportions, 1-1-1-1 to one of 4 treatment arms: A. Pilocarpine plus diclofenac combo, B. Pilocarpine alone, C. Diclofenac alone, or D. Vehicle, placebo. All treatments are administered twice daily, B. once in the morning and again approximately 6 hours later. Evening dosing is avoided to minimize nighttime pupil constriction. Rescue or as-needed dosing is not permitted during the controlled phase. The visit schedule includes screening within 28 days prior to baseline, baseline day 1, week 1, day 30, month 3, month 6, and month 12. Substudies include macular and choroidal OCT, aberrometry, Scheimpflug imaging, and corneal endothelial cell counts. Study population. Eligible patients are adults aged 40-65 with symptomatic presbyopia. They must have binocular DCNVA of at least 20/50 under mesopic conditions and distance vision, BCDVA, of at least 20/25. Refraction must be stable, and no refractive surgery should have been performed in the past 12 months. All participants must be able to provide informed consent and comply with the dosing regimen. Exclusion criteria. Patients will be excluded if they have narrow angles or risk of angle closure glaucoma, uncontrolled glaucoma or elevated intraocular pressure, history of uveitis or significant anterior chamber inflammation, moderate or severe keratopathy, severe dry eye or history of herpetic or neurotrophic keratitis, clinically significant cataract or pseudophakia aphakia that compromises accommodation, active macular or retinal disease, chronic use of topical NSAIDs or corticosteroids, systemic use of medications that interfere with accommodation, severe autoimmune disease affecting the ocular surface, pregnancy or breastfeeding. Operational policies further specify washout periods, restrictions on contact lens use, and mandatory baseline assessments such as gonioscopy, intraocular pressure measurement, vision testing, and corneal staining. Intervention. All study drugs are provided in masked bottles indistinguishable in appearance, viscosity, and odor. Compliance is assessed through bottle counts and electronic diaries. Dosing is strictly twice daily. If a participant requires open-label rescue medication, this can be requested after day 60. Assessments: near vision, distance vision, pupil size, intraocular pressure, slit lamp biomicroscopy, corneal staining, and patient questionnaires are conducted at each relevant visit. Safety is monitored continuously. The primary efficacy endpoint is measured at day 30, with standardized testing at 1, 3, and 6 hours post-dose. Endpoints. Primary responder definition, at least 3 lines of DCNVA improvement, binocular, mesopic, high contrast, at 3 and 6 hours post-dose on day 30. No detriment to distance, less than 5 letters lost in BCDVA. Tolerability adverse events, treatment-related headache, dim or scotopic vision, accommodative spasm, local installation irritation, or discontinuation due to adverse events. Sample size. The study assumes responder rates of 60% for the combo, 40% for pilocarpine alone, 25% for diclofenac alone, and 20% for vehicle. Based on these assumptions, approximately 220 to 250 participants per arm, 880 to 1,000 total, will be required to achieve 90% power with a two-sided alpha of 0.05. 2 pivotal studies will be conducted. Rescue medication, post-day 60. To reflect real-world practice, participants may request open-label combo treatment after day 60. This safeguard reduces the risk of off-protocol use. Rescue initiation is documented, and subjects remain in the trial for safety follow-up through month 12. Key exploratory endpoints include rescue request rate by day 90, time to rescue, reasons for rescue, and changes in patient-reported outcomes at the time of rescue. Statistical plan. Analyses will be based primarily on the intention to treat population. The main model uses stratified log binomial methods with 95% confidence intervals. Multiplicity is controlled through a hierarchical sequence. Combo versus vehicle, day 30, 3H. Combo versus vehicle, day 30, 6H. Non-inferiority of combo versus pilocarpine, and superiority of combo versus pilocarpine in tolerability. Intercurrent events such as rescue or use of prohibited drops are handled as treatment failures in the efficacy analysis. Multiple imputation will address missing data. Safety and monitoring. An independent Data Safety Monitoring Board, DSMB, will oversee the trial. Stopping rules are predefined for recurrent corneal damage, sustained intraocular pressure rise, and significant anterior chamber inflammation. All adverse events are collected through 30 days after the last dose. Patients are educated about possible dim vision and precautions for night driving. Ethics and data handling. The trial is conducted under ICH GCP guidelines, the Declaration of Helsinki, and all relevant local regulations. Informed consent is mandatory. Data are captured electronically with MedDure coding for adverse events and WHO drug coding for concomitant medications. Records will be retained for at least 15 years. Rationale for duration and follow-up. Although the therapeutic effect of pilocarpine and diclofenac can be documented within 30 days, extended follow-up is essential. Day 30 confirms efficacy after the accommodative system has adapted. Month 3 demonstrates persistence of the effect. Months 6 and 12 are included to ensure long-term safety, as chronic BI dosing requires regulatory evidence of tolerability over extended periods. This includes monitoring for corneal changes associated with NSAIDs, intraocular pressure effects, long-term impact on night vision, and rare retinal events. Together, this tiered design balances the need to confirm rapid efficacy with the responsibility to establish long-term safety. Conclusion. Presbyopia remains one of the most widespread and inevitable impairments of human vision. Current corrections are mechanical. They do not restore the lost biological function of accommodation. The combination of pilocarpine 1% and diclofenac 0.1% represents a promising strategy. Functional restoration through pharmacological training, stabilized for chronic use by anti-inflammatory protection. If successful, this approach could inaugurate a new era in presbyopia management, shifting practice from external correction to internal rehabilitation.